How many percent of the patients with HFpEF has type 2 diabetes? I would say almost 40 to 50% of the patients are having diabetes. Do you believe ARNI has an ancillary benefit in new onset diabetes in reducing the need for insulin? Yes, there are some data available which causes an improvement in the HbA1c and reducing the need for insulin. So there is a clinical presentation management in hospital 90-day outcome in Trivandrum, Kerala. The Trivandrum Heart Registry, they had a 55% of the patient hospitalized for heart failure. They had diabetes, and the heart failure diabetes prevalence there almost go hand in hand in various trials like PARADIGM-HF, Shift, EcoCart, Heart HF Action, Senior, Solve, Merit HF, Charm. Almost 30% of those patients, they were diabetic, and prevalence of HFpEF in diabetes and trials like DPP4 inhibitor trials, SGLT2 inhibitor trials like that, they have chosen patients, almost 10 to 30% of the patient, there was a prevalence of heart failure in those diabetic patients. Now, ARNI reduces the cardiovascular death, heart failure, hospitalization, improves the quality of life, irrespective of the glycemic status. So, whether it is diabetic or not, there is a 20% reduction in cardiovascular death, and there's a 20% reduction in heart failure hospitalization. And on glycemic control, if you can see the trial in the slide, that there is a trend towards better glycemic control compared to enalapril in patients who are on sacubitril valsartan. So there is a change in mean HbA1c and confidence by treatment group, screening, randomization, 1 year, 2 year, and 3 year visits. And new use of insulin was 29% lower with ARNI versus enalapril, and fewer patients were started on OHA therapy with ARNI compared to enalapril. So how does ARNI fare in patients with HFpEF? So that is a very important point. The treatment modalities that are very effective in HFpEF may not be that effective in HFpEF because the etiology is somewhere else. The pathophysiology is different. So it can have a cardiac origin, pulmonary causes, liver, renal, visceral adiposity, musculoskeletal features. So metabolic stress, aging, cardiac remodeling, ventricular vascular stiffening, sedentary lifestyle, there is a loss of cardiac, vascular, and skeletal muscle reserve and leading to HFpEF. So the other trials which are tried in HFpEF, the drugs like Charm Preserve in candesartan, PEP, CHF, top care the I Preserve, irbesartan. So drugs, spironolactone. So drugs that have been tried in HFpEF population, they could not reach a statistically significant values in when we have tried drugs like this. But okay, there are certain loopholes in certain trials, like in Topcat and a specific population like Western, Southern and Northern America, the population showed an improvement, whereas Russian and Georgian population, there was no improvement, and ultimately the trial could not reach a statistically significant proportion. Now, similarly, with when you see that that suggests that although there is an improvement trend of improvement in HFpEF also with these drugs, so there is a concept that may be helpful in those group of patients. Now, PARAMOUNT trial results in improvement in several subdomains in ARNI. Subdomains of ARNI like improvement in NT-proBNP, improvement in left atrial size, improvement in NYHA class. So it may not be that dramatic as it is seen with HFpEF, but there are certain soft points which improved with ARNI in HFpEF patients. So what happened with that in the PARAGON heart failure trial? So compared with valsartan, primary endpoint was it was a hypothesis that sacubitril valsartan compared with valsartan would reduce the composite outcome of total heart failure, hospitalization, and cardiovascular death. And so outcome-wise, there was an improvement in the heart failure hospitalization, less hospitalization in sacubitril valsartan arm. However, CV death were comparable, so there is no significant benefit in CV death arm. So there was a significant heterogeneity by ejection fraction and male or female patients. However, only interaction of sex and ejection fraction remain nominally significant. And those patients with an ejection fraction of 57%, there was an improvement. So up to 57%, there was a trend towards improvement. But those with an ejection fraction of 57 or beyond, there was no much difference between the two groups. So the EF cutoff for benefit in this specific PARAGON-HF trial was 57%, while sacubitril valsartan showed a benefit over valsartan alone. So total heart failure, hospitalization, and cardiovascular death by LV ejection subtype across spectrum of ejection fraction, that is PARAGON-HF and PARADIGM-HF trial. If you could see, that those with an ejection fraction of maybe less than 60%, there is a trend towards favors sacubitril valsartan. If we combine both the trials together, so the combining both the trials together, ejection fraction of is 60% or less. So all the heart failure patients with that ejection fraction will probably benefit from sacubitril valsartan, but those with an ejection fraction of 60 or more probably will not benefit, and it will have result will remain neutral.